Dr. Murad Lala, who is a consultant and head of department surgical oncology at PD Hinduja Hospital, Mumbai. Dr. Roma Pradhan, who is an associate director endocrine and breast surgery department, Medanta Hospital, Lucknow. Dr. Samskruti Murthy, who is at Kensi, head and neck surgical oncologist. Then Dr. Sangeet Agarwal, who is a senior consultant head and neck oncology surgery, Sri Gangaram Hospital. Dr. Shalin Shah, consultant at Gujarat Diabetes and Endocrine Foundation. And Dr. Smriti Panda, who is assistant professor, Department of Head and Neck Surgery, AIMS, New Delhi. Dr. Sunaina Sarkar, who is at assistant professor at MMSC, Varanasi. And Dr. Swati Rachna, who is in the nuclear medicine consultant at GCRI. I welcome all of you on the stage.
Dr. Tapaswani. Pardon? Yeah, as you're saying, heavily weighed in favor of the females. I think they kept the incidence of parathyroid disease in mind, which is 1:3, so it's perfectly matching. So I think a lot of work has, a lot of parts of this, what we were supposed to be discussing has already been covered. So if we have repetition, we'll just gloss over that and then continue with what hasn't been discussed. So just as a preamble, we know that the hyperparathyroidism came into vogue in around the 1920s in both the US and Europe as the symptomatic disease, which is, bulk of which is what we see today in India as well. It was with the advent of the multi-channel analyzers that the asymptomatic group of patients started coming up. And then in 2000s, we saw another surge in hyperparathyroidism because of the osteoporotic screening programs that happened. And today, it is the third most common endocrine disease. So we can see in the West, over 90% is asymptomatic. India is lagging 2 to 3 decades behind that. And it is now that we are seeing more and more of the asymptomatic group, especially in the tier 1 cities, and gradually it's going on to the tier 2 cities as well. The clinical manifestations, I won't go into this in detail, primary, secondary, tertiary, but the bottom line is the surgical management for this disease, and that is again reflected in our panel where majority of our panelists are all surgeons except for one endocrinologist and a nuclear medicine specialist. So coming to the first case, a 55-year-old postmenopausal lady underwent a comprehensive health check through her office. She did give a history of hypertension and acid reflux disease. She was on PPIs. Her serum calcium level was 10.6 milligram per deciliter. So no specific order, anyone can take the first question. If you see a lady or this patient or person came to you with these values, would you do anything else, or you'll just say that you're happy with it and you're okay with this?
So first of all, because the serum calcium is mentioned at 10.6, we would firstly, as a physician, so this is my perspective, yes. As a physician, the first thing would be what are the albumin levels? Because as we know that the bound calcium needs to be corrected for the albumin level. So if the patient has hypoalbuminemia, this would actually classify as hypercalcemia. So okay, so this one.
Correct. So yes, so it's important. And one more thing, point I would like to stress is that all the labs do mention. Sorry, I'll just go back to the slide. Yeah, so all the labs mention a very wide range, but they do not specify the age distribution in that range. So if you see anyone above 40 years, especially above 40 years, with a value of calcium value of more than 10, I think you need to further investigate that, because above 10 is usually seen in the younger age group and the teenagers, especially when there's a lot of bone remodeling happening. So this patient, okay, you asked for the albumin level and the corrected calcium came as 11.24. Next, what would you do?
So in this patient, we will take a history that whether she is taking calcium or not. If on the calcium, if she is not taking the calcium tablets and the calcium is 10.6, definitely we will go for serum PTH levels and serum vitamin D levels also, and bone scans of the patient also.
Okay, so yes, so this patient was not on calcium. The only medication she was taking was her antihypertensives and her PPIs. PTH 115, vitamin D3 24, creatinine 1.1. I don't have the BMD study here, but that was also done, I presume. Okay, next, what else would you do now with these values?
Her serum vitamin D levels are a little low.
Yes.
And I have to, first I would like to correct her vitamin D levels and then recheck her parameters. And other than this, I would also like to check the urinary calcium levels.
Okay.
Yeah, and phosphorus and magnesium.
So do you routinely do urinary calcium for all your patients?
Not for all the patients.
Not for all the patients?
Not for all the patients.
Okay. Anyone else? Anyone
So
different?
contrary to this, I would not like to correct vitamin D as of now, because that will lead to increase in calcium levels. So now the biochemical diagnosis of PHPT is done from our side.
Yes.
So you can label it primary hyperparathyroidism. Next comes the imaging studies in order to decide a plan of surgery. So right now we have a biochemical diagnosis, now we proceed forward for the imaging.
So you'll do imaging right now? Okay, so your diagnosis is?
Primary hyperparathyroidism.
Asymptomatic or symptomatic?
Patient is symptomatic, definitely, because she is having recurrent, she is on PPIs and BMD study is not
So
there
you're
yet.
considering the hyperreflux disease as part
There are
of?
subtle symptoms, but they are there, yes.
Okay. So so you are saying it's symptomatic hyperparathyroidism and you would go in for surgery for this patient. Everyone agrees, I'm sure. Anyone in the audience? Fair enough. Would you image this patient now? Yes, Tapaswani.
In fact, if you look at the statistics, it says that 60 to 70% of the patients whom we call as asymptomatic are actually having symptoms, because the symptoms are so vague that it's associated with the daily sort of issue, like gastric reflux, or they may have some bone pains or some cognitive disorders. So it's a 55-year-old. So anything that, even the reflex that we are seeing, as you said, asymptomatic, is probably a part of the symptom that is happening.
Yeah, I agree. So they say that if you dig, really go into the history and you dig deep enough, and not just from the patient, but from the patient's relatives, especially for the mood swings, etc., you'll get that out from the patient's relatives. So if you really look into it, most of the asymptomatic are actually symptomatic. So coming to imaging, yes, ma'am.
We would like to do an abdominal scan also in this
Okay.
patient before we actually tag her as asymptomatic. We will have to rule out renal calculi also. So probably before tagging asymptomatic and symptomatic, I think the workup would further need an abdominal scan also.
Shalini?
Yes, workup would obviously, if you're looking at the workup, we would also require, serum creatinine and calculate the eGFR. You would also require a DEXA scan, to basically, label whether the patient is, asymptomatic, requiring surgery or not.
Okay, so that is if you go into the discussion of, there's very clear guidelines on which asymptomatic patients you're going to operate and which you would keep on follow-up. So all of you have agreed that this patient needs surgery, correct? So you will all image this patient? Okay, so anybody please take it up now. What imaging? This is the gamut of imaging that we could do. What is it, your protocol? What does your protocol say?
Begin with a high frequency ultrasound to localize, to look for any parathyroid adenoma or gland enlargement. Then I would also do a system AB scan. So probably,
Okay.
yeah.
Does anyone do a system AB before an ultrasound? I think this is partly discussed, because if you do a system AB scan and if that localizes a gland, it's sort of your radiologist can focus into that area to confirm that yes, this is the offending gland. So anyone does it in that order? Everybody does an ultrasound and then system AB.
It's often seen that once one hits onto the diagnosis of a parathyroid, hyperparathyroidism, patients often come with a system maybe to us. And the next step is primarily anatomically localizing the enlarged gland.
Okay. Apart from ultrasound and sesame B, does anyone have any other protocol in your institutes? Yeah.
No, I was just saying that most of the places, at least in Ahmedabad, Swati can correct me, whenever they do system maybe, they always do sonography with that. These are the radiology centers which has nuclear medicine facilities. So they do it together, so.
Okay, so,
yeah.
so everyone does a sesame B, and is Dr. Sareen here, Deepak? I think he's left. I think there are certain centers in Delhi who are moving on to a PET choline, F choline, yes. So anyone has experience on that? Dr. Gaurav?
Well, yes, PET choline can be done, but primarily for patients where you are doing a reoperation. I would not usually use it for primary surgery. The primary evaluation for or imaging in patient undergoing primary surgery would usually be restricted to a MEB scan, a well-performed MEB scan, and a high-resolution ultrasonography.
Okay.
Rarely we can go on to 4D CT, but nothing beyond.
Fair enough. Okay, I don't think we'll go into, I think everybody knows the physics or the thing behind a color Doppler. You always do a color Doppler along with your ultrasound?
Yes, that's
Yeah, I think that is
yeah.
important to differentiate a lymph node from the parathyroid adenoma. And a sesame B will always be with a SPECT, Dr. Swati?
We do dual phase scintigraphy, maybe scintigraphy, there's a dual phase. With we do ultrasound also, it's just to confirm our diagnosis, and SPECT CT.
And a SPECT CT, yes. So the sensitivity increases significantly
Yeah.
when you combine it with a SPECT CT. And of course, so this is the localization. 4D CT is only a troubleshooter. Does everybody agree to that?
Yes.
Yep. Or anyone does?
Whenever there is discrepancy between ultrasound or maybe or there's some confusion, then 4D CT is pretty good imaging.
Correct.
Because we are able to see it ourselves. So it's pretty nice, and we are using it quite frequently.
For 4D CT. So, okay, we do it only when, as you said, as a troubleshooting, when there's discordance between the ultrasound and the sesame B. And a PET choline, yes, Tapaswini.
Just a comment, when we're talking about the 4D CT, I think it should be cautiously used if you are having a young patient, because it is said that the radiation exposure to the thyroid is almost 50 times higher. And also if you have a female who is pregnant.
Yeah.
So.
Okay, so that's right. But again, the sensitivity of PET choline is significantly higher than even a 4D CT, and especially when you're looking at multi-gland disease, I think that's where a PET choline comes in. So this shows that 90 to 95% sensitivity and specificity for that. So let us go back to that first case. That was a 55-year-old lady, but just say we have the same parameters in a 32-year-old lady, the same parameters, raised PTH, raised calcium levels, corrected calcium of 11.24. What would be your protocol? It's the same? Yep. So we sent this patient for a sesame B scan, and the patient was sent back to us saying that we can't do a sesame B scan because she's missed her periods, and she did a pregnancy test and she was pregnant. So now this is a pregnant 32-year-old lady. Now what will you do for this patient? Yeah.
Do an ultrasound.
Okay.
And also MRI is a good modality where you can use on a pregnant woman.
Okay, but would you want to investigate this patient further?
Yes.
She's pregnant.
Yes, I would like to investigate, and I would like to know in which trimester she is in.
So she's just been detected. She's come back to you, you've done a pregnancy test, and she's so probably first trimester.
Okay, I would like to follow her up.
Okay.
And see, and if it is, if the calcium levels are really high and she is symptomatic, then probably plan a surgery in the second trimester when it is safe to do.
Okay, how many of you would operate on this lady in the second trimester? Or would you all keep her under close observation, let her complete her pregnancy, and then operate on her? Charlene?
Yeah, so I think because the corrected calcium levels are around 11.2, so initially at this period of time, we may try medical management in the form of adequate hydration, low calcium diet, because, as per guidelines, as, if the serum calcium levels are more than 11.4% persistently in spite of, these measures, then probably we may think of, getting her operated in the second trimester.
Okay. The criticality, yeah. Yes,
Calcium
ma'am.
levels, calcium should not be restricted because that itself can increase the parathyroid hormone levels. You should give a recommended daily-
You're going to supplement her with more calcium.
No, the recommended daily dose should be given. It
Should
not
be given to
restricted.
this.
Yeah.
Tapaswini?
And also the other thing to be noted is for fetal hypocalcemia during this particular.
So I think the danger is not so much to the mother, but the danger is for the fetal monitoring, because the fetus goes into hypocalcemia as a corrective mechanism because the parathyroids in the fetus shut down. So the moment that the delivery happens, it becomes a neonatal hypocalcemia, and that needs to be aggressively corrected. And that, if we are aware of it, then we look for it and we correct it. So that is the important point over here. Anything
As
else?
far as the calcium is concerned, if the question of normal calcium diet goes in scenarios where the calcium is in the low normal range. So whenever patient has hypercalcemia, and there will be no risk of renal stones or calcium reabsorption that we are thinking about.
We are thinking about. Dr. Munito, any comments on this?
This is a dramatic situation, the pregnant women with primary hyperpara, and I think it should be treated as fast as possible.
So you would treat this patient in the second trimester? You
Yes,
not wait
in the
for-
second trimester. Yeah,
Okay.
yes. It's very dangerous for, as you said, for the fetal survival also.
Okay. Okay, so we all come to surgery.
Just a question that how easy or difficult it is to manage a fetal hypoparathyroidism versus doing a surgery. So how you will grade it and how you will take it for the patient? Like if patient says you can do anything and I'm ready for both the things. So how do you take the decision about it?
So our endocrinologist was pretty confident that she could manage the pregnant woman during her entire pregnancy, and her view was that we wait for the patient to complete pregnancy and then go ahead with the surgery. We spoke to the pediatrician who was going to be involved at the time of pregnancy, and he said he could manage it, but quite frankly, I don't know how he's going to manage
So
it.
what the panelists feel about it? They are the same situation or it's difficult? Because I feel it will be a very difficult task to do it.
So studies have shown that, if you are able to maintain the calcium, say, below 11, then the chances of, IUGR, preterm delivery, fetal hypocalcemia, post-delivery or tetany or seizures are significantly less, because higher the calcium levels, higher the suppression of the fetal PTH. So if you're able to maintain a calcium of 11 or less throughout the pregnancy, then probably you can continue, think about continuing. But if over a period of time, if the calcium levels keep on rising, the patient is not able to manage with just hydration, and then probably you go with second line therapy after discussion with the patient, and still it doesn't get under check, then it needs to be operated.
Dr. Gaurav?
Thank you.
So, I was, please, I wanted to caution that it's not only the severe neonatal hypocalcemia I'm bothered about. Pregnant women with hyperparathyroidism have much higher preeclampsia, IUGR, intrauterine deaths. Are you willing to take all that risk? So, unfortunately, this patient has been detected well in first trimester. You have plenty of time to prepare her for surgery during the second trimester. Majority of such procedures would be fairly straightforward. Do we not operate on so many other endocrine tumors during second trimester of pregnancy? So unless there's a specific contraindication to it, best is to operate.
Operate this way.
So we have a experience of pregnancy during hyperparathyroidism during pregnancy of some cases. So we have a multi-specialty good pediatric department. So our pediatrician said that we can't save the child, so please do parathyroidectomy as soon as possible. So do it in second trimester as early as possible. So we did it.
Okay, so I think the consensus here is that if there's no contraindication, go in for surgery in the second trimester. Okay. So now, okay, irrespective of that, this a patient you're taking up for surgery, clear cut, concordant, single isolated parathyroid adenoma. Everyone does a minimal access over here, minimal access means a small incision. Or does anyone do for four-gland exploration still? I think we all agree. I do not know why the Miami group is still going in for a four-gland exploration, but apart from them, I think the entire world has shifted onto a focused parathyroidectomy. Adjuncts, we've all spoken of that. In my practice, whenever I remove a parathyroid, I always confirm on frozen section. Does anyone else do a frozen section here? Routinely?
Yes, sir, routinely frozen section.
Routinely frozen section. I think Dr. Gaurav, you said selected, you also do it routinely. Okay, intraoperative PTH, we all monitor it, but when do you do your pre-excision or do you do it pre-induction? When do you take your first sample? When do you take your second sample? And do you keep taking a serial samples or you just do two values?
So we do only 3 samples just before making the incision and after 5 minutes and then 15 minutes. So only 3 samples.
The rest of the panel?
I would do a Miami protocol, follow that. So when the patient is wheeled in induction has happened, then the first baseline goes in. And then after my excision, 5. And then if I see a drop, then fine. Otherwise, we repeat it again at 10 and then at 20 if it doesn't fall down.
Okay. And yeah, yes.
Do you get your results so within 5 minutes? In the best of Indian labs, 17 minutes is the best turnaround time.
We take about
PTH.
30 minutes in our
So it is, I mean, we stick to the usual pre-induction, pre-excision, that is after mobilizing the tumor, 5, 10, 15 minutes post-surgery. In patients with hyperplasia, renal hyperparathyroidism, or some other reason for suspecting slower dynamics, we do it 20 minutes later, but usually 5, 7
So I think just one point,
Yeah, so sending lot of PTH sample costs.
Yes.
And we are in a cost constrained country. What we do is, when the patient is wheeled in, that is one sample. Once we remove it, the specimen goes for frozen section, we wait for 20 minutes.
Okay.
We send a 20-minute, and if 20-minute sample is not right, then we conclude that it is not right.
So what I do is just to avoid this surge of the PTH, just pre-excision, I take my first sample, and then 10 minutes post-excision, I take a second sample and wait for the result.
So let us be practical. What Dr. Patel has told is very good, and you also told is right. Do not waste the resources.
Correct.
We are in the corporate sector where every single test matters. So pre-incision, when the patient is getting induced, just send one sample, and after 15-20 minutes, not exactly 10 minutes, after 15-20 minutes, by the time frozen section or other things are okay, then send another sample. Turnover time is minimum 30 minutes, minimum.
Thank you. Yes, Dr. Sunil.
So just a little comment that we were discussing, that is sampling from the internal jugular vein and sampling from the peripheral.
Yeah.
So that makes so much of a difference, because doing a pre-excision when you have the entire space open and the IJV close by, and then doing it after you're finished.
What I do is pre-excision from the IJV and post-excision from the IJV. You get a dramatic difference. It makes you feel very happy. I agree, but I don't think there's any harm in that. But any objections to that?
I have done many times from IJV. But now I think, why should I take a load? After removal, something anesthetic should also do. But I have done many times from IJV.
Yes.
So both things are okay. IJV or peripheral, it's absolutely same. Nothing, no much difference.
What we do is, to save time, we just close it down, and after 20 minutes it is sent. As soon as we get the report, patient is extubated and is wheeled out of the OT. So it saves time.
Yeah, probably.
Frozen comes, you are confident.
Do you always do frozen? Always. Okay, so I think we just, for time's sake, okay, this is one case that we had, again, I think it was very similar, so I'll just jump through this. Nicely localized gland. We did a 4D CT also, and on 4D CT you can see it light up, and then you can see the washout. That's the gland lighting up just pre-aortic over there. So this is it, and of course I think this is an ideal situation where we could either, if you have the facility, you can do a robotic surgery. That's what we did for this. this was the gland that has been isolated and we excised it. And I think this is one of a very good indication for a robotic surgery or a minimal access thoracoscopic surgery as well. Again, which was emphasized time and again in the talks before that, you should always know your embryology, so know where they should be, but always when you can't find it, look where they can be. And let's jump into the second case. A 65-year-old gentleman on dialysis, end-stage renal disease, corrected calcium 8.7, phosphorus 7.9, PTH 1300, vitamin D3 8, alkaline phosphatase 280. Okay, this patient, Dr. Shalin, medication, patient was on a medical line of management, but on medical line of management, these were your values.
So, with a any symptoms as such?
No.
Asymptomatic.
Asymptomatic.
So, with the sevelamer, that is potassium binding agents and calcitriol, if the patient does not have other signs of, CKD such as refractory pruritus, or if the person does not have, a fragility fracture to go along with it, or does not have a very severe hypercalcemia or a very severe hyperphosphatemia, over a period of time with medical management, if slightly probably correcting the vitamin D would also to some degree bring down the PTH levels. We would like to observe this patient for a period of time and then, see over a period of 2 to 3 months in which direction he goes.
But aren't these the classical indications to take this patient up for surgery? You've got an extremely high PTH, you've got a calcium phosphorus product of 60, that's above 55, which is again an indication. So shouldn't you be taking this patient up for surgery?
So yeah, ideally a patient who has a PTH of more than 800, gradually the patient developing into tertiary hyperparathyroidism will also have a rising level of calcium. So if the patient, if it is tertiary hyperparathyroidism, the calcium level should be on the higher side, and in that scenario we should definitely operate it.
Anything anyone else would like to contribute? DEXA. Yeah, the DEXA scan, I don't have the values here, but the DEXA scan did show a T score of less than 2.5.
I would also get an ultrasound of the neck because if the gland size, the parathyroid glands are very much enlarged, so they would go on to develop nodular hyperplasia, which might not respond to your medical management.
So you will get an image, any other imaging or just an ultrasound?
Along with the system maybe.
Along with the system maybe.
See, in this patient, you have not given sinacalcet. Just give sinacalcet, don't do anything, just a medical management. Calcitriol is being given, sevelamer is being given, just give sinacalcet. PTH is 1300, it will come down. But it goes beyond 1000 after on sinacalcet, only then operate, don't do operate before that.
Okay, so the important thing is give a good chance.
Calcimimetic, sinacalcet, 30 mg, OD or BD.
You can go up to 180 milligrams per day.
Yeah, but 60 mg is quite enough.
Yeah.
The only thing with sinacalcet in this scenario would be that the calcium level is already 8.7. So that's what I was saying.
It is corrected.
Yeah, so that then there will be a change in the PTH set point and you may have some degree of decrease in calcium. But ideally in this scenario, if this is the case, the calcium level should be on the higher side if it is tertiary hyperparathyroidism.
Okay, so assuming this patient you've given all your medical line a good trial and it has failed, you've taken this patient up for surgery. What surgery would you all do?
So we have an experience of this type of surgery, but unfortunately we did 3.5 gland removal and half healthy gland after the frozen section 2-1 we implanted into the forearm. So, but after 2 weeks, what we find that PTH levels were again more than 1800. So what we did, we removed one pocket from the forearm. And after that, after 2 weeks of that, we again find that 1800, more than 1800 of the PTH. So, actually, I don't know what should be done in Dr. Panda.
So we need to know whether the patient is planned for a transplant in the near future. So if the patient is to be kept on long-term hemodialysis, then just doing a 3 or a 3.5 gland, there's a high chance that the remnant gland is going to again start producing more PTH. So in those cases, it's better to do a 4 gland and then implant it in the
so we'll do it, 3.5.
Yeah. So what we follow is near total, like more than 3.5 gland. We see the normal looking gland, and then leave a small part of it, and in this case, we definitely use ICG for the remnant part, and
Oh, that's
also
good.
autofluorescence help in such cases of HHPT. And we also make sure that we remove the upper part of the thymus, because a lot of supernumerary glands are
Yeah,
also
and one more
present.
thing I think to add to that is if you are leaving it behind there, then always put a surgical clip
Yeah, of
there,
course, yeah.
just as a marker for future reference. You wanted to say
Yeah,
something?
yeah, I agree with Dr. Roma. It's usually 3.5 because the gland, whatever half gland we keep in situ, will do better work as compared to the outright transplanted gland.
Okay, so we did surgery for this 3.5, we implanted into the forearm. On second post-op date, the patient has developed seizures. And these were the values. So what are you thinking of? So corrected calcium was 6.2 only, PTH has dropped down to 90, vitamin D3 is 12, and ECG showed changes. So hungry bone syndrome. Now is hungry bone syndrome, so is it a sign that you've done a successful surgery, or is it a complication of your surgery in the sense that you've not preempted it, you've not looked out for, anticipated it, you've not built up the patient's calcium reserves, and that's how it has happened. So how would you manage these patients? Dr. Shalin, this patient comes to you, patient is going in for surgery. What would you do to prevent this?
So first of all, before the surgery, as we said, that there is evidence which suggests that correcting the vitamin D levels before the surgery does help decrease the risk of post-operative hungry bone syndrome. As far as in this scenario, I think over a period of time, if you follow this patient, I think along with the calcium, the phosphorus levels also should go down. That basically helps us clinch the diagnosis of a hungry bone syndrome. And then as far as, management of this patient is concerned, because the patient is showing ECG signs, we would obviously go with, IV calcium replacement in this scenario, along with activated vitamin D in this scenario, and the ideal dose is around between 2 to 4 milligram per kg per hour, and the calcium level needs to be repeated every 8 to 12 hourly, and the dose needs to be adjusted to keep a calcium within the normal range.
Such cases of SHPT, we really post-operatively, immediately we start on oral calcium as well as boluses of IV calcium, that we prophylactic start in such cases of SHPT, definitely.
In all your
Because we
secondary
expect-
hyperparathyroidisms?
Yes, so
Okay.
that is the reason why, it is pretty helpful. Otherwise, patient will give high dose of rocaltrol, calcium, and then IV boluses. So that really helps in managing such patients.
So just a minute back, I was about to ask that what was the bone health?
That is
one
what I
part.
asked. Correct.
That was madam was also
Yes, so
asking.
indirectly you saw
Second
that
thing-
the alkaline phosphatase was so high, so
Yes.
indirectly it shows that there's a rapid bone
Second
turnover.
thing, I don't know, correct me if I am wrong, whatever hungry bone syndrome, post-op day 2, hypocalcemia, hypophosphatemia with hypomagnesemia has to be there, at
Yes.
least prolonged. That is what the actual definition, what I have read. Correct me if I am wrong. I think on day 2, you cannot label them exactly as hungry bone. Maybe, yes, it is going towards hungry bone.
Okay.
I agree, Dr. Sashi and Dr. Roma. See, we have to preempt that this patient is going to develop severe hypocalcemia after surgery. Your surgery is successful, no doubt, because you have asked that. But we have to preempt, and immediately after surgery, start the patient on IV calcium and oral calcium as soon as the patient is able to take orally on high doses. Because you already told the high bone turnover disease, T-score was minus 2.5, osteoporosis was there. This is a very common scenario in secondary hyperpara. So hypocalcemia and that to severe grade was bound to happen.
Yeah, and phosphorus will not fall in this because phosphorus will remain high because of SHPT.
Correct.
So that will remain, and you have to keep your nephrology colleagues in loop, of course. They are the ones who actually refer these cases to us.
A small practical tip, if you are expecting this, your patient should be given a PICC line or a central line, because lot of calcium through peripheral veins will create lot of havoc to these patients.
Okay.
This patient is a CKD patient, so already they have AV fistulas.
Yeah.
So it's very difficult to manage. I agree that central line is better option, but peripheral lines also work very well.
Peripheral, but peripheral central line, PICC. That is what I am saying.
So that's
Not
what
the
we have-
peripheral veins.
So one hand already fistula is there, so that hand is
That
blocked.
is all right. I
So other hand,
I am not talking about the patient
I
with the
agree.
fistula.
But other hand, peripheral lines is okay, and central line don't put in the hand, put in the neck only.
Wherever you want to put, but
Because we have
central
to-
line
we have
is
to protect the
required
hand.
if a patient needs a prolonged IV calcium.
Yes,
Because otherwise all these
Usually
veins will
1 day,
get
2 days is
destroyed.
sufficient.
I would like to add one point. Because of the continuous calcium infusion that we give, we have now shifted to IV boluses 8 hourly. So we put 2 ampules in 100 ml NS. According to the, of course, CKD patient, we have to see the fluid that we are giving. So that is even more comfortable for the patient, and we can have a good night's sleep, I'm telling you, with this. Because otherwise infusion, it's very difficult to manage also. With no residents, of course, in the corporate setup, there are few of them.
Yeah.
Of course, in an institute, you have multiple residents with you, so no issue in that case.
Okay, can we just quickly go to the next case? 36-year-old lady, again underwent a comprehensive health checkup, no comorbs. Calcium was 8.7, phosphorus 2.9, PTH 93, vitamin D3 9.3. So how would you label this patient?
Serum creatinine?
Creatinine was normal. So anybody, yeah. So yes, would you operate this patient or would you image this patient? Okay, so I think it's very clear that this is a case of vitamin D deficiency. You just correct that and reevaluate her, and I'm sure 2 to 3 months down the line, it will come back to normal. Her PTH will also come back to normal. And it's very important to differentiate this two, the vitamin D deficiency versus low vitamin D as a protective mechanism in cases of primary hyperparathyroidism. So this is what we need to differentiate, and that's why I highlighted that case. So the next case, a 41-year-old lady, no comorbidities, low-grade fever, 2 months, pain in the throat, ESR 41, TSH 6.9, ultrasound neck showed a heterogeneous thyroid echogenicity which was suggesting thyroiditis. The picture was fitting into a thyroiditis picture. But there was a query, hyperechoic nodule inferior to the right lobe of the thyroid, which could be a parathyroid adenoma. So how would you take this patient management forward?
Again, PHPT is a biochemical diagnosis.
Yes.
So do serum calcium, PTH, along with vitamin D and serum creatinine, then only make a diagnosis.
Okay, this is your values.
So calcium is on the higher side, vitamin D is okay, PTH is slightly higher. Can you give me the range of PTH, because that is like...
The PTH upper limit was 60.
60?
60.
Yeah. So definitely corrected calcium is on the higher range, right?
Yes, just on the higher range.
So then maybe we can see the symptoms. Then this you can classify as asymptomatic if she's not having any symptoms.
So probably we can add phosphorus and ALP along with that. What ma'am was telling, there is a comprehensive full panel is what we recommend.
Okay.
Because sometimes phosphorus can be low normal. That will give us a clue towards a PHPT.
He or she had fever.
Yes.
Just hydrate the patient. Everything will be okay. Reassess after 1 month.
After 1 month. So you'll say keep the patient on observation.
See, calcium corrected time only 10 points.
So
PTH is not very high. Don't do anything now.
Okay. What we need to highlight here is just because a radiologist has said query, adenoma, don't chase it and don't operate. This patient was underwent an sestamibi scan elsewhere. This patient was taken up for surgery, underwent a right inferior parathyroid adenoma. Thyroiditis was the diagnosis. Right inferior parathyroidectomy. Final histopathology report that was shown to us was just parathyroid tissue seen. 1 month later, corrected calcium was 10.7, PTH was 88. So again, what is it? Is it a failed parathyroid surgery? Was it an unindicated parathyroid surgery for this patient? And what will you do next?
So I think first of all, looking at the first report, doesn't matter what the upper range of PTH is. Whenever the calcium level rises, the PTH should fall down. So whenever a PTH level is more than 20 picograms per ml, that suggests that it is a PTH dependent hypercalcemia, and hence probably you need to look into causes of PTH dependent hypercalcemia, and they include not only just parathyroid adenoma and all. You have to look at other causes like hyperparathyroid jaw tumor or milk alkali or FSH, and even lithium induced hypercalcemia is PTH dependent.
So anyway, we were little at a loss of what to do for this patient. As usual, we sent it off to the endocrinologist, and they're the ones who take a detailed history, not the surgeons. And then they picked up this history that the patient's mother also had elevated calcium levels, and that triggered the thing that this could probably be FHH. And of course, the creatinine clearance ratio, the calcium creatinine clearance ratio was done, and it was diagnosed as a familial hypocalciuric hypercalcemia, which are the patients you should never be operating upon, because surgery does not cure these patients. It's a mutation in the genes that's causing it. And generally they are asymptomatic. You don't have to do anything for this group of patients. I think we have time for one more. 45-year-old lady presents with recurrent renal colic, proximal muscle weakness and fatigue, constipation, vague abdominal symptoms. Neck examination showed a palpable mass in the left lower paratracheal region. So, investigations, this is it. So with this investigations, what would be your clinical diagnosis? Anybody, please.
So it is a clear-cut case of primary hyperparathyroidism.
Okay.
As per your slide, ultrasound neck has 3.5 centimeter inferior to left lobe, and system AV scan is also showing the left inferior parathyroid.
Fine. Anything else?
But there is palpable neck mass.
It's a palpable
which
neck
is
mass.
unusual with primary hyperparathyroidism. So, and also the PTH levels are very high, calcium levels are very high. So, I would think about parathyroid carcinoma.
Correct. So these are all the red flags that we have that are pointing at us. You got an extremely high PTH value, a very high calcium, a palpable mass, as she said. So these are all red flags that this could probably be a carcinoma. System AV scan showed an inferior uptake. So this patient underwent a focused parathyroidectomy. It was a suspected giant parathyroid adenoma. Would any of you have done a FNAC on this?
No.
Okay, so no one will do an FNAC on this. Intraop was a firm mass adherent to surrounding structures. Frozen section, parathyroid tissue cannot comment on malignancy, which is expected. They can't give us on frozen section that it's a malignancy or not a malignancy. Final histopathology came, parathyroid carcinoma. Now what will you do for this patient?
Okay, if it was just the focused parathyroidectomy
Yes.
that was done, ideally you should do a parathyroidectomy with the ipsilateral thyroid.
So would you have done in this patient without this final histopath report? You've gone in for surgery. Would you have done a classical hemithyroid with the parathyroid with a settled compartment without a diagnosis?
With the intraoperative finding, it says a firm mass adherent to the surrounding tissue that is like suspicious of a parathyroid
But are you
carcinoma.
justified in doing the extent of surgery that you want without a tissue diagnosis of carcinoma?
Yes, I would.
You would do it.
Certain things I would have done before venturing into the surgical theatre with this patient. One, because of flags that we were talking about, which is suggesting that this is not probably an adenoma that you are looking at. Either we would have discussed with our own ultrasonologist, because even the USG can pick up a carcinoma. It is said that if the depth vis-a-vis the width of the lesion is more than 1, 95% accuracy of telling you that this is a malignant parathyroid. And the other, it would have also picked up some lymph nodes, if at all they are there. And if still in doubt, would have had imaged it better with a CT scan. When coming to surgery, I don't think I would have been comfortable doing a focused, because I feel that I would have had ventured it much more in its exposure and also in the clearance.
Okay. So just to step back a little, Dr. Swati, would you have done a PET scan for this patient?
Yes, sir. It's a role of FDG PET CT for the staging of parathyroid carcinoma.
So such type of patients in which calcium is 14.2 and PTH is 1200, we more often found that there is a fibrosis in the parathyroid adenoma also. So we have a giant adenoma series in which there are not a very good planes, so we can't assume as it is a parathyroid carcinoma, because parathyroid carcinoma is a very rare entity. So we often found that fibrosis in the parathyroid adenomas also. So we should, I think we cannot do such type of extensive surgery on without any tissue diagnosis.
Harsh?
So when we have enough radiological details preoperative to indicate that there is a possibility, and this is something we do in our routine practice, although this is a very rare entity, all the patients are counseled that if there are any intraoperative findings and we do confirm this to be a carcinoma, then we will be doing a left hemithyroidectomy or a right hemithyroidectomy along with the procedure. So they already have that consented.
Okay.
See, a surgeon should not have gone inside. Whatever the surgeon has done, based on the clinical diagnosis, it was not warranted. Clinical diagnosis was parathyroid carcinoma. It was very clear. A palpable gland, very high calcium, very high PTH, irregular borders. So it was not a case of adenoma, it was a clinical diagnosis of carcinoma. If carcinoma is there, I would have gone for bilateral neck exploration with en bloc ipsilateral hemithyroidectomy and ipsilateral central compartment dissection with the same pathoid gland. This was the minimum surgery.
You are saying a bilateral neck
Yes.
dissection?
Maybe a unilateral neck exploration with a normal incision.
Because what
that is important.
it is a carcinoma.
Yes.
And many times it can happen that the gland which is increased in size and carcinoma, it may be non-functional and any other pathoid gland may be hyperfunctional. So with that diagnosis, bilateral, it is described in the books with a pathoid carcinoma that it should be a minimum bilateral neck exploration and ipsilateral hemithyroidectomy.
Bilateral neck exploration?
For parathyroids.
Okay.
With ipsilateral hemithyroidectomy.
We have, over period, we have 4 parathyroid cancer patients. We have done hemithyroidectomy and central compartment node dissection on that ipsilateral side. They are doing well. I mean, I don't know.
Yesterday we had presented a case series of 11 patients.
No, I understand.
Yeah.
But these are 3 patients,
Yeah.
11 patients, 5 patients. I don't
It's a
think
clinical
we can-
diagnosis.
I don't think we can make a state of the art
Fair enough. These are, I mean, whatever you do
I
probably would be justified provided you can.
There's
you
no
have
way
a
we can do that.
But you
method
have done
behind
right that ipsilateral hemithyroidectomy is the minimum thing when you are finding a ipsilateral parathyroid palpable gland with a very high calcium and PTH.
Now this patient comes to you, post-op, with the diagnosis. Will you go back and reoperate? Will you follow up this patient or will you give adjuvant therapy?
Reoperate.
You will reoperate?
Yes.
The panel?
Yes, definitely we will reoperate and we will do hemithyroidectomy of the ipsilateral side and with the.
How soon will you go back? It's been 10 days, you've got this report, 10 post-operative day. Will you go back immediately? You will wait 6-8 weeks?
I think there is no option of wait. I think we should do as soon as possible.
Why can't you keep this patient just on, monitor the PTH? If the PTH has dropped down to normal.
Definitely, I will go for
And
follow-up
just
only.
keep patient with the PTH monitoring. Anybody agrees or
Yes.
disagree?
I agree to that.
No?
Sir, regarding the previous thing and then maybe this thing as well, because there were signs were there that it could be a carcinoma, I think the condition very well could have been avoided by doing a CT scan. And it would also pick up if there is a enlarged contralateral gland or not. So bilateral neck exploration probably no, hemithyroidectomy yes. Now, intraoperatively we are doing the hemithyroidectomy, that is fine. But if you have to do it now that the carcinoma is out, even if you defer it a bit so that there is no inflammation, you can go in a bit later and take out the remaining thyroid and central compartment SOS if needed in those cases.
Okay, I think we are short of time. This patient was put on follow-up, went on to have a raised PTH later on, 10 months later, and came with this lung metastasis. So I think that's another discussion, but we are short of time. And I'd like to thank the organizers and all my panelists. Thank you very much. Thank you. Thank you.
Go for a photo, please. Please.
For photo, and I request all the people in the audience to just spend few more minutes with us. We are announcing the prices of free paper and poster. Would like you all to encourage the young people who have worked so hard. And I congratulate Murad also. This is the only panel in this entire conference which has reached to 6 cases. Great. Dushan. Yeah. I invite KK and Jyoti madam on the stage. And Aditya, start the function.
KK had to leave because his flight is at 4 o'clock, so the car was organized at 2 o'clock and the session went on. But I'm there.
अरे एनी पास आके थे
So, first of all, I would like to
Please wait, don't go.
Thank you all, and I would like the winners to be here. First, I will announce the winners, and then one by one they can come and they can take their prizes. For the paper presentation, we will start from the gold medalist, and Dr. Ashish Shaini. Dr. Ashish is here? Yeah. Best paper presentation, Dr. Ashish Shaini.
He's from where? Tell, no? Where are you from?
Ma'am, Ames Delhi.
Huh?
Ames Delhi.
Ames Delhi. Very nice. Okay. Congratulations.
Love.
Yeah. So this is instituted for the first time, the best paper award and the certificate. So all the juniors will be excited to participate in next year's competition.
પછી ચેન્જ કરી દે
First medal on your neck, huh?
પછી બધી કાઢે
Yes.
પહેલા પેપર So the silver medal for paper presentation goes to Dr. Yakshi Patel. She is from Rajkot. And the third winner is Prakash Sutar.
Say from where you are.
BVCI Guwahati. Dr. Ashok Das, right? And one of the mentor is here only. Now we will move on to poster presentation. The first prize winner is Preeti Dingra.
Is he there?
On her behalf.
Wow. ENB. ENB should know.
The second prize goes to Ruju Vadavia. Madam, તમારું નામ? હા? Girl power?
Girl power. Always girl power, yeah.
And the next winner is Sarah Giri. Sarah is here? Yeah. So congratulations to all the winners. They were exceptional posters and papers, and it was difficult for judges to choose from that, but they have chosen the best. Now I will invite Sanjeev Bhai to give vote of thanks. Yes.
It is only to appreciate what you all have done. Nothing from my side. You all agree it was one of the fantastic conference. On the last day, last session, when people had to catch, the hall was almost full. And it was such a good discussion on parathyroid, which I started last year, that we are discussing only thyroid. We must have a dedicated parathyroid. We had it in Calcutta, we had it here. And looking at the knowledge sharing and the attendance, I think we have really succeeded at this session. The conference had a 400 plus registration. That shows trust in their academic program, capabilities, and the social programs also. So we all agree that it was a very, very successful conference, all thanks to them, and also the live surgery demonstration, which is impossible in today's era. They could manage the permission. So please all stand up and give them a standing ovation. I really appreciate each one of them, and I may not be able to individually name them because it's a huge committee, but really from the ISTS and from me, I'm really very thankful and will remember for the rest of my life this conference. Yeah. Yeah, now. And now I have to have a pleasant duty of giving this FHNO collar, ISTS collar to his name. So he has to remember that he has a huge responsibility.
This calls for a standing ovation.
And I have no doubt that he will perform. It is very nice.
So good afternoon. On behalf of the organizing committee of ISTS 2025, it is my distinct honor and privilege to deliver the vote of thanks for highly successful 7th Annual Conference of Indian Society of Thyroid Surgeons. We are profoundly grateful to our esteemed national and foreign faculty, especially operators, keynote speakers, and president of our society, Dr. Jyoti, and office bearers, of course, for gracing this event and sharing their insightful experience. Your presence and wisdom has set a new elevated standard for the conference. Next, a heartfelt thank to all our distinguished speakers, session chairs, and abstract and free paper presenters from across the globe. Your dedication to sharing cutting-edge research, clinical best practices, and lively discussions is the very essence of this conference. The quality of the scientific discourse has been truly exceptional. And now, a big shout out to our tireless efforts of our core scientific program team, Dr. Aditya Joshipura, Dr. Parin Patel, Dr. Dushan Malik, and of course our leader, Dr. Kaustubh Patel. Also, please join me in congratulating and welcoming once again new president of ISTS, Dr. Kaustubh Patel, with a big round of applause. To our valuable delegates, students, attendees, we thank you for your active participation, challenging questions, and enthusiastic engagement throughout these past 2 days. Your presence is the fuel that drives collaborative research and medical advancement. We hope the knowledge and connection you have gained will inspire new avenues in your own practice, and we wish you all the best for that. Our sincere appreciation goes out to our generous sponsors and industry partners, Medtronics, Estrin, Hexagon, Ketlin, Kepler, Pfizer, Stryker, Cipla, Merrill, Arelic, New Care Hygiene Private Limited for their unwavering support. Without their commitment, an event of this magnitude would not have been possible. A massive thank you to the unsung heroes, the entire organizing committee, the volunteers, the administrative and routine staff of SCG Asta Cancer Center under the leadership of Mr. Sudarshan, the CEO of SCG Asta Care, and Dr. Soma. Bhavin Shukla and his team RX events under the leadership of Mr. Hardik Chandrana, and I will personally like to appreciate Stuti. And the AV team under Mr. Alex for absolute flawless work. Finally, our sincere thanks to the entire team of Hotel Hyatt Regency and Messrs. Vanguard Holidays for their great hospitality. We look forward to see you soon. Good day.
Okay, so one announcement that the first 3 prize winners for paper as well as poster, if they convert this into a publication, the journal will accept their papers for publicating in our event journal. You know that I am an editor of a journal, Head and Neck Journal.